as we think about the different CDK4/6 inhibitors and how we might choose to use them in patients who present with metastatic disease, one of the things that we do know is that there appears to be some tumors that are exquisitely driven by the estrogen receptor. These are patients that I mentioned previously that come in with perhaps a long treatment-free interval, high levels of ER and PR, lower grade, and lack of if you will, visceral metastases. And these are patients that clearly maybe do well with endocrine monotherapy, such as fulvestrant. And then we have a group of patients that have higher risk characteristics. And these are patients who exhibit tumor features that are more concerning. These are tumors that, for example, are higher grade, absence of the progesterone receptor, short treatment-free interval, and of course the presence of visceral crises. And one of the things that's important as we looked across the CDK4/6 inhibitors is it appeared that these drugs have activity in these patients, and specifically with the drug abemaciclib, substantial or significant increases in response rates were seen in these patients with these high-risk features. One of the questions that comes up is, well, why do the drugs work so well in these high-risk features? Well, if the tumor is not driven only by the estrogen receptor, are there other ways that these drugs could potentially work? And certainly one of the things that is quite interesting is the recent data that has come out of the Harvard group demonstrating that abemaciclib and some of the other CDK4/6 inhibitors can activate the immune system. This might be very critical in a tumor with genomic instability that is driven by factors other than the estrogen receptor. So the observations that the response rates are this high, for example, in patients with poor prognostic features, high-grade absence of PR, liver metastases, suggests that these drugs may be doing things other than just targeting CDK4/6. Bottom line is that these are patients who present this way are excellent candidates for drugs such as abemaciclib or the other CDK4/6 inhibitors.
The pooled analysis from MONARCH 2 and MONARCH 3, which have shown the level of benefit in different subgroups, are really important for clinicians to understand. What we've seen in the analysis is that there are certain baseline characteristics that we know are prognostic that can actually help you differentiate those patients who get the biggest degree of benefit from the addition of a CDK4/6 inhibitor. And if clinicians are thinking about whether they should offer the combination to patients who present with metastatic disease, then I think an understanding of this is helpful. Patients who have tumors that are of higher grade, tumors that lack progesterone receptor, and patients for whom they have an early onset of relapse within less than 3 years since diagnosis, these patients have a poorer prognosis with endocrine therapy alone and are set to gain the most from the addition of a CDK4/6 inhibitor. On the other hand, patients who relapse many years later perhaps have a very hormone-driven cancer, ER and PR strongly positive, perhaps a lower grade tumor, and a distribution of disease that might be just in the bone alone. We know that those patients can do fantastically well with endocrine therapy alone. And while the addition of a CDK4/6 inhibitor might give a little bit more additional benefit, there is an option for patients to be treated with endocrine therapy alone and then reserve the addition of these agents for when they progress on their aromatase inhibitor, as shown in the PALOMA 3 trial or the MONARCH 2 trial with these classes of agents.